42-year-old man presents with an oral cavity lesion, toothache, and weight loss. He is known to have been HIV positive for 6 years, but he does not follow a prescribed antiretroviral regimen because of personal beliefs. The vital signs are blood pressure 110/80, heart rate 89, respiratory rate 17, temperature 100.8. Physical examination revealed an ulcerative lesion on the lower lip. The lesion was friable as evidenced by contact bleeding and tender on palpation. A CT scan showed the lesion to be a solid mass, invading the mandible and spreading to the soft tissue of the oral cavity. A biopsy was obtained to determine the tumor type, which showed monotonous diffuse lymphoid proliferation of large cells with plasmablastic differentiation and an oval to round vesicular nuclei with fine chromatin. The cells are immunopositive for VSC38C, DNA of which of the following viruses is most likely to be identified on the tumor cells. Okay, so we could see that there was a male who was HIV positive. He presented with an oral cavity lesion, toothache, and his CT scan showed a solid mass which was invading the mandible and spreading to the soft tissue and oral cavity floor. So we know that there is it has got something to do with his it is some sort of oral cancer, and they also give us the biopsy was showed diffuse lymphoid proliferation of large cells with the plasmacytic differentiation. So based on that, okay, let us see what the explanation is. So the description of a plasmablastic neoplasm affecting the oral mucosa in an HIV positive male patient. This suggests a plasmablastic lymphoma of the oral mucosa type. So this lymphoproliferative entity is most commonly associated with HIV infections. So this plasmablastic lymphoma is nothing but a type of a B-cell lymphoma. Okay, and this is more commonly seen in patients who have HIV, although HIV negative cases in immunocompromised patients have also been identified. But what you should keep in mind is its association with HIV. And this is considered to be an EBV-induced neoplasm because EBV DNA is identified in the tumor cells in most cases. So you need to know that it's associated with, it's seen in HIV positive patients who have an EBV infection. They can go on to develop this particular type of B-cell lymphoma. So usually these plasmablastic lymphomas involve the oral mucosa and the jaw, with rapid invasion and spread to extraoral sites, including the nasal cavity, paranasal sinuses, orbital tissues, and occasionally it develops in other sites with similar morphological features. So plasmablastic lymphomas of the oral mucosa type occur more often in HIV positive patients according to the WHO classification. Other classification topics include neoplasms also occurring in immunocompetent patients such as Burkitt and Burkitt-like lymphomas, DLBCL, centroblastic and immunoblastic lymphomas, extranodal marginal zone lymphomas of the mold dish type, peripheral T-cell lymphomas in the classic Hodgkin's lymphoma, as well as neoplasms occurring in patients with other forms of immunosuppression, such as the polymorphic B-cell lymphomas. So with HIV in particular, you need to associate this plasmablastic type of lymphoma. And HIV-associated malignancies are thought to result from diminished immune control over the neoplastic cells due to decreased quantity of competent T cells. A latent EBV infection is a factor that favors lymphoproliferation via several mechanisms. So this is not very high yield, but you do need to remember some of these keywords. So one mechanism is linked to the latent membrane protein 1. So what this does is that it mimics the CD40, which is located on the surface of lymphocytes. And when this self-aggregates, it provides a proliferation signal via activation of the nuclear factor kappa JK signal transducer activation. So you don't need to know how it acts. You don't need to know this nuclear factor. That's too much detail. But you do need to remember that this is the keyword here, latent membrane protein 1. This is the part of the EBV which is responsible for the proliferation. Also very important to know is that it mimics the CD40 on the surface of B lymphocytes. So that would be the takeaway point here. And another thing, this is also a little extra, but you can keep at the back of your mind that it also allows affected cells to escape apoptosis through the BCL2 induction. Okay, so that was about HIV, EBV, and their association with plasmablastic lymphomas. So now, although CMV also contributes to cancer development and is found within neoplastic cells in numerous types of cancers, CMV is not associated with this particular type of plasmablastic lymphoma of the oronucleoside type. HHV8, I'm sure as you all know, is associated with a neoplasm, occurs more in HIV positive patients, and a well-known non-lymphoproliferative malignancy associated with HHV8 is Kaposi sarcoma, which is the most common association that we know of. HSV1 is not reported to be associated with any malignancy. HPV-associated malignancies, you all know, is the cervical, vulvar, vaginal, penile, oropharyngeal, anal, and rectal cancer, but no lymphoproliferative disorders are associated with HPV. Okay, so this question, I think it's something new. Especially the cancer association with EBV, the plasma lymphoblastic lymphoma, which is not something that we come across very often, but a high yield question because you need to know the latent membrane protein 1 and how it mimics CD40. So those would be the takeaway points from this question.
Thanks for watching. Please give a thumbs up and subscribe for more.